Good morning, and good morning to some, and good afternoon to others. My name is Dr. Sidney Freeman Jr., and I am so excited that you are with us today. I am the president and founder of the Liberation Movement, and this is Saturday Soul. And on our program today, we're going to focus on the topic of Black women's health in the context of the COVID-19 pandemic. And we have a special guest that will be presenting her information with us on today. And so if you are watching, please put in the chat your name and where you're watching from. We want to acknowledge you. We also would ask that you share this link with your friends and loved ones, those that, particularly Black women, that you think would benefit from this information. We are excited not only that we have a special guest that will be sharing her expertise with us today, but we also have a special guest host that will be bringing on in the next few minutes. But before we go too much further, we want to make sure that you understand what grounds the work that we do. And so something that I have a Black transformation. And what we want to do is share a little bit of that model with you.
The work of the Liberation Movement is grounded in the Black transformation model. We believe that there is a 5-step process that will lead to the advancement of our people. These steps inform all work that we engage in. The first step is decolonization, which we define as the holistic process of letting go of colonial practices, values, and culture, adopting and returning to indigenous ways of knowing and being. In other words, a change of mindset centering African ways of thinking and living. The second step is abolition. We define abolition as being willing to fight injustice and dismantle practices, systems, institutions, and power structures. The third step is revolution. I define revolution as a fundamental change from the status quo that facilitates new ways of knowing, being, and operating. The fourth step is liberation. To be liberated is to be free from forms of spiritual, psychological, and physical oppression and captivity. The last step is sovereignty. When we say sovereignty, we are stating that we will be committed to supporting and/or establishing Black-owned and operated institutions. So, we take seriously Romans chapter 12, verse 2, where it says, "Do not conform to the pattern of this world, but be transformed by the renewing of your mind." Black transformation is our assignment, and we are committed to help liberate our people spiritually, socially, and psychologically through educational initiatives.
All right. We are so elated. We are so elated to have a special guest with us today. Well, she actually is not a special guest. She's the co-founder of the Liberation Movement, Dr. Lynda Freeman. She has an extensive background in the area of public health. She has a bachelor's of Arts in Health Administration. She has a Master's of Public Health from the University of Alabama at Birmingham. And also, she has her doctorate in health science from Nova Southeastern. And so we're so glad that she is with us today. I was putting together the poster, and on last weekend I looked at the poster, and it had me on there and our guest speaker, and it hit me. It said something doesn't look right, and so I said, why am I trying to facilitate this? And I have a woman and public health expert in my own house and a part of the liberation movement. So I'm so glad that she's consented to lead out in this broadcast. This will allow me to step aside and just enjoy and learn from the discussion today. So, without further ado, welcome, Dr. Freeman.
Thank you so much. I'm excited to be here. I'm excited for the topics we're talking about today. Honored to have Dr. Curry on here. So I'm ready. I'm ready to get started.
All right. And so, what we want to do is all those who are watching, please share this link. If you're on Facebook, share that link with your loved ones, family, and friends. Also, if you're on YouTube, feel free to share the YouTube. Also, if you are watching, please put your name and where you're watching from in the chat. We want to make sure that we acknowledge you and looking forward to a wonderful presentation. So listen, I'm going to step to the side and let Dr. Lynda Freeman take over the rest of the program. Thank you so much, Lynda, for doing this.
No problem. Glad to do it. I want to bring Dr. Curry up front in just a second, but before I just want to review some of her background. Dr. Gwenetta Curry is a lecturer of race, ethnicity, and health in the Usher Institute at the University of Edinburgh. Her research interests are racial and ethnic health disparities, maternal health, and Black family studies. And her present research analyzes racial disparities in treatment and infection rates of COVID-19. She is the co-author of the Uncovered COVID-19 Evidence Review entitled, What is the Evidence on Ethnic Variation on COVID-19 Incidence and Outcomes? And also the co-author of Sharpening the Global Focus on Ethnicity and Race in the Time of COVID-19, which has recently appeared in The Lancet. She's a member of the Royal Society's Delve Initiative and a senior research associate in the Global Health Governance Program in the University of Edinburgh Medical School. She is a member of the Medical School Equality, Diversity, and Inclusion Alliance and the UK Inclusive Data Task Force. So as you can see, we have an expert on our hands here, and we're getting ready to be set up for something really good. So I want you to help me to welcome Dr. Gwenetta Curry to the stage.
Hello, Dr. Freeman. Thank you for having me here today. I'm glad to be able to be a part of the program.
We're so happy to have you here, and thank you for accommodating us, because I know your day is starting to wind down over there in Scotland, and we're just kind of getting started here on the Pacific Northwest. So we appreciate you sacrificing to be here.
No problem. Excited to be here.
Yeah. Thank you. Before you dive in, can you just give us a general idea of why do we even need to talk about this topic? Why do we need to make people aware of Black women's health and COVID-19?
Mm-hmm. Well, for me, Black women's health has been at the center of my research from the start. I've have wonderful women, Black women in my family that have made me the woman I am today. I look across our communities, and in a lot of ways, Black women are winning, right? They're getting degrees, we're excelling, we're getting these high positions, but our health has not gotten better. And so I think now is the time for us to really focus on some of the issues that are, that Black women are dealing with and that are having a negative impact on our health. With COVID-19, I really drive this home in a lot of work that I do, is that COVID-19 didn't create these issues. They exacerbated these issues. And I think that now with the highlight, being on, Black women and disproportionate effects of COVID on our community as a whole, we need to address those and be aware of some of these disparities and what we can do to improve it.
Excellent. Well, I'm gonna let you have the stage. I'll circle back after you finish. Thank you so much.
Well, thank you. I am going to let's see, upload my slides here. Hopefully this goes smoothly. It's always one of those things where you want it to go smoothly and then it doesn't show up. But hold on, I can do it this way. All right. Window. I'm going to share screen instead of slide because it didn't show up just now. But here we are. All right. So today I'm going to talk about the impact of COVID-19 on Black women's health in the US and the UK. I think it's important to talk about both countries because they have very different medical systems, and in the US a lot of times we talk about how important it is to have access to healthcare, and we have huge access issues in the US, but the UK is supposed to have socialized medicine. So we asked the question, with socialized medicine, does it really or has it really improved the life chances of Black people in the UK? Right. And so today you'll see some of the data I present, and there's a lot of parallels between what we see happening in the US and the UK. And we have to ask ourselves, why is that the case? This is just a brief outline of the today's presentation. I will talk about the rates of COVID-19 in the US and the UK. I will go over some comorbidities that increase the risk of severe outcomes from COVID-19, as well as linking in structural racism to poor health, and talk about the chronic illnesses that are impacting Black women disproportionately. And I will close with a discussion on Black women's mental health, not mental health, maternal health. Although I think mental health is vastly important, it's not a part of the conversation today, but we can talk about it after if we like. Okay. So this is a graph showing the COVID-19 deaths for those who were 65 years and older by sex and ethnicity in the UK. Now, this is for the first wave of COVID-19. And when I saw this graph, I immediately saw like, okay, what is happening? So we see that Black men had a huge disproportionate impact of COVID-19, but also Black women. So across the board, Black people are being disproportionately or dying at a disproportionate rate from COVID-19. The reason this was so important in the UK or across the UK is that Black people only make up 3% of the population. So if Black people making up 3% of the population, with the average age being 30, right, significantly younger than their white counterparts, which the average age is like 45, a lot of questions were raised, like, why is this the case? This is a similar graph showing the same thing, but those who are 9 to 64 years old and the rate of death per 100 people in England and Wales. So I live in Scotland, and Scotland has a huge issue around data. A lot of the times they don't collect ethnicity data, and when they do, it's only a small proportion of people that would respond to it. And some of the conversations that people don't feel comfortable reporting their ethnicity because they feel it may be used against them, but in a lot of cases they don't collect it at all. So it becomes a situation where you can deny there's an issue of race because the data doesn't show. But England has a lot of data available. England and Wales, they do a great job. And so when we talk about the UK, now this data is from ONS, which is the Office of National Statistics. One of the efforts I was involved in this year was the Inclusive Data Task Force with ONS, trying to get better representative data. But COVID-19 really highlighted these issues. Now, this is the intensive care data. This is one of the first bits of data that came out in the UK on COVID-19. And at this time, there wasn't a lot of conversation about the disproportionate rate of death among Black people. But when the report came out and it was no conversation, I was raising my hand like, what's happening? Like, why aren't we talking about this issue here? And as you can see from this graph or this table, all ethnic minorities were disproportionately affected, but particularly Black and Asian ethnic minorities across the UK. Now, this is data from the US, and this is 2021. And again, it shows that a disproportionate rate of cases, hospitalization, and deaths from Black, Asian, Hispanic, and American Indian populations. But again, it's one of those things that you have to put things in context. In the US, Black people make up around 13-14% of the population. In the UK, it's 3% of the population. In both cases, Black people are disproportionately affected by COVID compared to their white counterparts. So, what are the similarities, right? Then we discuss, well, what role does where you work have on your vulnerability to death from COVID-19? As the US and the UK, this table demonstrates that ethnic minorities are overrepresented in service jobs. On the right-hand side, you'll see deaths involving COVID-19, and it's broken down by jobs. On the left-hand side, you'll see the ethnicity listed. And for taxi and cab drivers and care workers and care workers and home care workers, clearly there's a disparity there. Security guards and related occupations, nurses, bus drivers. And one of the things that really resonated here is that these are occupations where people did not have the choice to work from home, right? During this time, this is in May 2020, when people, we were just coming out of the lockdown or just starting the lockdown, and people had the option to stay at home. So if you were able to stay at home, you were protected. All of these occupations that when people had high rates of death, they were on the front lines. They were considered essential workers, right? It's funny how these essential workers becomes the ones that keep society going when there's a crisis. But if you think about how you treat these particular people in these occupations, a lot of times they're dismissed, right? And this is something that as a society we need to do better with, right? And it's about the food, drink, and tobacco services operatives as well. So people always are going to have to eat. So who's gonna take care of food processing? Who's gonna refill the shelves? Those are the things that had to continue happening during COVID-19. This is an image that was on the front page of one of the newspapers here in the UK. And it says, remembering the 199 NHS workers who died from COVID-19. This image was important, right? Because what do you see? There's an overwhelming representation of Black women, Black men across the UK that work for the NHS who have died from COVID-19. And the question is, why is that the case? Aren't they, how is there a disparity when everyone in the NHS are working under these same conditions, supposedly? Well, Unison did a survey. So it's the Unison Black Worker Survey. And they said that Black workers were working in fear. The results demonstrated that they were more fearful of infection, more concerned about PPE access, more fearful or onward infection to family. So if they get infected at work and bring it home to their family members, a lot of people from ethnic minority background work or live in multi-generational homes where if they work in a hospital and they bring it home to their elderly mothers, that it could be a severe reaction. Again, all of this happened prior to a vaccine being available for the community. Right? They were less likely to get sick pay. This is something that it has always been the case. Black people don't have access to sick pay in the US and the UK. Overwhelmingly, they're the ones that do not have access to sick pay, and they continue to go to work even when they're not feeling well, right? So when you are unwell and you should be staying at home, you push yourself to go to work because you know that what? You have to pay your bills, you have a family dependent on you, and if you don't get paid, you can't pay your bills. So they were also more fearful of losing their jobs. If you don't go to work and your job is in jeopardy. And so when you're in a precarious position, you're going to make sure that you're at work as much as possible, right? They were more worried about reduced income. So if they reduce your hours or they decide that your job is redundant, then your livelihood is in jeopardy and you can no longer take care of your family. And this goes hand in hand with meeting the cost of living. One of the major issues that are going on right now in the US and the UK is the increased cost of living. Just your day-to-day living costs for heating and cooling bills, your grocery bills are extremely high. And so this is a constant concern. And so if you don't have the protection to be able to take the time off work when you're sick, you're going to push yourself just to meet this the costs. So these are some UK health disparities. Again, you'll see that it mirrors that of the US. ONS data shows that 73% of Black adults are considered to be overweight or obese, with which is the highest percentage for all ethnic groups. I will say that new data just came out today showing it did decrease to 67.5%, but it still remains the highest among all ethnic groups. Between 2016 and 2017, the percentage of new cancer diagnoses decreased for all ethnic groups except for Black and other ethnic minorities. The reason cancer is such a major issue is that when it comes to Black communities, particularly Black women, a lot of the times cancers are diagnosed at the later stage. So not getting the screenings that we need, inadequate time, increase your risk of cancer being found at more advanced stages or spreading to different parts of the body, and not being able to be treated properly. In England, Black African and Black Caribbean ethnic groups have a higher risk of hypertension than a general population. Again, all of these mirror the same data that we see in the US, with hypertension driven by stress, stressful jobs, all of these comorbidities had a negative impact or increased the risk of death from COVID. We found that with COVID-19, the increase of death, risk of death was very high among those who were diabetic, as well as those who were considered to be overweight. So this graph is important because it shows, this is CDC data that shows the obesity rates by states. And you see that clearly across the American South, Louisiana, Mississippi, Alabama, in deep red, show that over 35% of the population is considered to be obese. You'll see right down the middle with the Midwestern states, Iowa, Nebraska, and I used to live in Nebraska. Again, these are over 30% considered to be obese. And the next graph kind of maps onto this. This shows the COVID-19 risk levels in 2020 by states. And again, you'll see at the bottom, the red is high level of risk of severe COVID-19 outcomes. All right. So this is kind of a thing with increased risk of death and increased risk of COVID-19 going hand in hand with comorbidities such as obesity. African American women obesity prevalence shows that it was disproportionately affected by obesity epidemic, with 4 out of 5 African American women being considered obese, and currently 1 out of 4 African American women being diagnosed with diabetes. So this is an issue within our community, and a lot of times the conversation around obesity becomes sensitive because they're like, oh, well, how do you address this, right? And I think this is a major issue because how do you address an issue if you don't have resources within your community, right? And like safe places to exercise, health access to healthy food. Those are things that have to be addressed. So this is a publication from some of my previous research on obesity, and it shows that the impact of educational attainment on Black women's obesity rate. Because the understanding is that you increase educational attainment, so the more degrees you have, the easier it's supposed to be for you to have adequate resources to live a healthy life, right? To exercise, to eat a healthy diet, and have better health outcomes. Well, the data demonstrated that that wasn't exactly the case for Black women. As education increased, it did not reduce their risks, their overall risks for obesity. And some of this was directly related to stress. So stress hormones such as C-reactive protein remain high regardless of the levels of education. So C-reactive protein is something that's released when your body is feeling stressful. And it's something that is natural. So if you experience stress, these levels of hormones in your body increase so you can deal with the stress. But what happens when you're stressed at work and stressed at home and you never reduce that level to something what we call a homeostasis, and your body has a negative reaction. So this increased the risk of type 2 diabetes as well as hypertension. I really like this graph because it kind of demonstrates how all these things are linked together. Racial discrimination, some people like to talk about experiences of racism being a moment of inconvenience. So something you experienced that was inconvenience, it was terrible at the moment, but then you move past it. It's not that simple, right? So if you follow the first arrow at the top, it shows that denial of goods and services, right? So let's say you wanted to buy a new house, right? You know how hard it is to be Black and buy a house in US. And it was very interesting. Like earlier this year, there's an article that came out where a Black family was trying to sell their home, and they had their pictures in the home, and and it was clearly appraised at a lower price than when they removed all the pictures and had a white family show their home, their white friends show their home, right? It was a massive difference. So there's a lot of discriminatory practices when it comes to Black people selling and buying homes. So what this leads to is Black people living in poor conditions. So there's a decreased quality of access to healthcare, decreased quality of access to green spaces. One of the major things that we saw under COVID-19 is that in the UK, when we were on a lockdown, we only had 1 hour outside of the house to go exercise. Right, that was the idea. You got an hour out of the house to go exercise. Well, I mean, simple enough, right? 1 hour outside, maybe go for a walk. But the data showed that Black people have 3 times less access to green spaces than their white counterparts. So if you were on lockdown in a small apartment, you literally are stuck there all day, right? And that does terrible things for people's mental health when they can't go outside their homes and at least get fresh air and go for a walk and exercise, right? So you say living in poor conditions links to decreased quality of healthcare, as well as increased risk of poor mental health, anxiety, depression, and substance use. Down the middle, you have the psychological stress. So again, you're stressed out at home, you're stressed out at work, you never reaching a level of homeostasis, you're just constantly under stress. What does this do to your body? The physiological response to stress is to increase the hormones such as cortisol and C-reactive protein. And with these in your body at high levels for a short period of time, not a problem. But if you have these high levels of hormones racing through your body for extended period of time, you have increased risk of cardiovascular disease as well as increased blood pressure, right? So you'll see how racial discrimination is more than just an inconvenient moment or bad event that happened one time. This is something that's persistent and pervasive and can affect you for your entire life. Now, maternal mortality. This is a huge conversation because again, in the UK, we have socialized medicine where everybody's supposed to have access to healthcare, right? So why is it the case that the maternal mortality rate for Black women still remains high? In the US and UK, Black women are more likely to die from a pregnancy-related complication than their white counterparts. They have a report here they call the Embrace report, where they kind of go through and review what's happening with maternal health across the UK, and what it demonstrated was that Black women in 2019 they were 5 times more likely to die from pregnancy-related complications. They did the report again this year, and it's 4 times more. There's a group here that just released a report. They did an excellent survey with gathering stories across the UK of Black women's experience in maternal health, and they're called 5 times more. All right. The CDC latest data demonstrated that Black women die at a rate of 2 to 3 times higher than their white counterparts. All right. And so the data is very similar, as you can see, from the US and the UK. Black women in the US with at least a college degree have higher rates of pregnancy-related mortality as their white counterparts who dropped out of high school, right? And this is a graph that shows the pregnant women with COVID-19 by race ethnicity in United States as of between January 2020 to May 23rd, 2022. Right, so just recently. And this shows that non-Hispanic whites had the highest, Hispanic had the next highest, and then Black women had the third highest, right? Again, you have to look at this graph and also consider the proportion of Black pregnant women in the US, right? In the UK, very similarly, Black women make up 53% of the women that were committed to the hospital with COVID-19, but they only make up 20% of the pregnant women who are in the UK. Right. So you see this a disproportionate rate of infection among Black women or severe reactions to COVID-19. Right. So there was a huge push to increase um, vaccinations within the community because that was kind of frontline fighting against the severe reactions to COVID-19. And so there was a lot of efforts going into trying to address the issues around severe reactions to COVID-19 because they found that with the vaccine, there's not a higher rate of severe reactions, right? So a colleague of mine, Dr. Jiva John, she's actually a OBGYN. She did some research and she actually interviewed Black and South Asian women who were under maternity care in the UK. And in this data, it was very clear that, again, Black women were not being treated the same way as their white counterparts. And it was very the age old thing where their pain is not being taken seriously. And I usually talk about this in to account of Serena Williams. Serena Williams is a millionaire, right? And what we know after she had her baby and she experienced the complications, they didn't want to listen to her. She had to really advocate to get them to listen to what she's telling them and tell them there's a problem, this needs to be addressed. All too often, when Black people or Black women in particular are expressing a need for medical attention, it is constantly dismissed or their pain is not taken seriously. There is a survey that was done for medical students in the US, and they still have the same myth that Black people can endure more pain than their white counterparts. I could not believe that this is still a thing in the 2000s, right? And this is based on age-old myths about Black people not needing pain medicine. And when they do seek out pain medicine, they're seen as, drug seeking, right? So within this study, I have some quotes. For experiences of racial discrimination, it shows institutional. This is a direct quote. It says, and when they've asked, they have refused to stitch it back again. And they just told them to keep taking painkillers because they were in huge pain. And my friend, I have seen she couldn't sit. Right. So this is an issue where the patient told the doctor that, she's in pain, this needs to be restitched. After you have a baby, sometimes you tear and they stitch you, right? And you go from there. And they didn't want to address the pain. They didn't want to address her issue. They just told her to take painkillers, which is really Tylenol here. That's all they give you is Tylenol, right? Personal mediated racial discrimination. It's like the person said, like, if I had a really bad experience for the first one, maybe I would have thought the same and maybe I would have delivered in India or something, right? So they're saying that, if they had a bad experience, they would have just delivered their child in another country. Right, which is very interesting because people are very proud of the NHS here and socialized medicine, what they've done for the community without their in terms of filling this gap around access. And in a lot of lights, they're seen as better than a lot of other countries. But what this research demonstrated that some of these women really felt that they could have delivered their babies and had a better experience in their home country than they had in the UK. Right. And this one says internalize. So sometimes people internalize the discrimination they experience. Say, oh, it's nothing that serious. But at the same time, there was a white woman who were having the same issues, but taken more seriously. Again, saying that their pain was being ignored while they were attending to white patients more attentively, right? So these are the same issues that we see across the US that we just documented here in the UK. And these experiences of racial discrimination can have huge, and this study was done during the time of COVID. So to navigate that space during COVID was huge because a lot of things were moved to online. They did consultations on the phone rather than you coming into the office because of the risk to you as a pregnant woman. As we saw, there are increased risks with COVID-19. And so communication was something that people depended on into making sure that they had a healthy, safe delivery for their babies. And conclusion, so comorbidities increase the risk of death from COVID-19, but racist structures created these conditions for Black people to have a higher risk of exposure. As I said, where people lived, the resources that they did not have in their communities, or where they worked. So we know that Black women work in a lot of the caring positions. So they work as nurses, they work as home care nurses. So they were frontline workers, right? So they were unprotected and overexposed. And so they had higher risks of contracting COVID-19. Poor housing and working conditions. One of the huge things they found with COVID is that ventilation matters. So if you live in a home without good ventilation, or you live in a home that was multi-generational, and you had the risk of bringing COVID home to your family members, this increased your not only your risk of death, but also the risk of death from your elderly family members. Medical risk mistrust is at the center of all of this. So when we talk about medical mistrust, a lot of times we talk about historical experiments that have happened on Black people. But as our research demonstrated, that Black people are being mistreated today, even within the medical field, right? When they're trying to receive care. Now, vaccine uptake in the US and the UK have the lowest rates in the Black communities. And the recent data here show that in African communities in the UK, at every age level, African people have the lowest rate of vaccine uptake. And what we know is that the vaccines have, had a huge impact on decreasing the severity of COVID-19, and as well as preventing death. So we know this is something that is important for the community to take part in, but there's a huge issue around mistrust. And I understand it because it's like, if for years you have dismissed and ignored the needs of communities around food access, access to healthy, spaces to exercise, but now you're showing up at their door and saying, hey, take this vaccine, knowing that we've been experimenting on in the past. This is a huge issue, right? So I think that a lot of times we have more recently look to community leaders to being the ones to kind of guide these conversations and to gain the trust of the community, to convince them to take the vaccine to protect them from COVID-19. I think as we are going through this pandemic now, COVID-19 remains an issue, right? Even though we're trying to move to a live with it space, it's still very prominent, with thousands of people dying every day across the US, right? So there's a lot of work left to be done, and we have to do a lot to protect ourselves. And first line of defense is to get vaccinated, right? Thank you very much. If you have any questions, please contact me or let me know at Afropuffs with a Z, and that is my what is it called? That is my Twitter handle. Thank you.
Your handle, yeah.
Yes.
Thank you so much, Dr. Curry. This was excellent. This was rich information. After hearing a presentation like this, it's like, what do we do? What can we do to fix it? But it's so complex and deep. But we have to start taking steps to do something about it. And a lot of the time, it's on the burden of those who are oppressed to just kind of advocate for themselves and do what we can do versus trying to convince others who are the oppressors to help us out. So
Mm-hmm.
with that in mind, there are like faith-based organizations, nonprofits. There are us, like the liberation movement. We are seeking to meet needs of the Black community, to support our community in regards to Black women's health. What are some things that we can be working on
Mm-hmm.
to
I
improve
think
these
it's
health outcomes?
Yeah, I think that as Black women, we take care of everyone else, right? We're constantly taking care of, our husbands, our children, our mothers, other people in the community, and I think that it's going to be important, or it is important for us to start taking better care of ourselves, exercising, and that was another scholar who did some work about taking a moment of peace, right?
Mm,
The moment to have that mental space to just block out everything and just have that moment of peace. And she actually interviewed some women, and they talked about just going to the bathroom and have that minute of peace from the chaos in their house, right? In those moments, I think that we have to start understanding it is not selfish to take care of yourself.
mm-hmm.
I think sometimes when we have that moment of self-care, you're like, oh, should I be doing this? Shouldn't I be helping out with this? Shouldn't I be taking care of this? Because it's always something that's pulling at us, or something else that needs to be done, or someone that's calling us to, help them with this. But we have to be reflective and say, okay, how am I taking care of myself? There's one, I used to have this saying on my little profiles that you can't pour from an empty cup. And I don't know the origin of that
Mm,
quote, but I thought it was very impactful, because it's like, wait a minute, how can you help someone else if you yourself, are not whole? And I think that we have to do better with taking care of ourselves. And I think with faith-based leadership, it's important, because I think we can kind of like work together and hone some of those skills, and talk about some ways that you can take care of yourself and take care of each other. Even like walking groups, exercising together, encouraging everyone to get moving.
mm-hmm.
Me and some of my family members, we do these weekly competitions on like the Fitbit or whatever,
Mm-hmm.
on who's gonna get the most steps, right? Just to get people moving. Because yeah, exactly. So I have mine, right? And so it's one of those things to encourage you to get moving, and how you can feel better. And I know there's challenges with time, right? How do you
Mm-hmm.
make the time to do these things when you're working two jobs and taking care of family, right? It's like finding the moments where you can make that happen, right? And when you talk about healthy eating, it's not necessarily throwing out everything that we think, when they put these pictures of like, oh, this is what Black people eat, they have these like stereotypical things like, we don't eat every day, right? There's no way
Right.
that people can eat soul food every day, right?
No.
Right. um but really, encouraging, increasing consumption of fruits and vegetables. How do you make them accessible for all communities? Are there things that, different faith-based initiatives can do to help, mind that gap between what's available to different communities? When we were in Texas, we did these focus groups in rural areas where they were considered food deserts, and they
Mm-hmm.
had this huge gap of, where do you get your fresh fruits and vegetables from, when they had a gas station / grocery store to access things from? Like, what do you do? Right. So I think there's a lot of work to be done. I think we definitely need to pull on some of our government officials that we voted in to represent us, to help with some of this. But there's things that we can do within the community as well, working together.
Yeah.
Mhm.
Yeah, definitely. And that made me think about the issue of mistrust also. Um, so we're in 10 years, it'll be 100 years since the Tuskegee experiment, right?
Mhm.
And you think about, well, there were community liaisons that the U.S. Public Health Service used to,
Yes.
reach.
Eunice
So
Rivers.
it's, yeah, so it's definitely a challenge. And I know some people think, oh, that was almost 100 years ago. But in your presentation, you gave current examples of how, we're still facing the same inequities, the injustices in
Mhm.
healthcare. Um, could you speak to the importance of showing and talking about the data? Because sometimes there are those who don't want to believe that these things exist because it is so horrible. But can you
Mhm.
just speak a little bit to the importance of seeing this data and talking about it?
Yeah, I think it's important to be driven by the data because I think anyone can just get up and say something, right? And I think that too often you have different leaders that's just standing up talking, right, without evidence. And I think that if you want to have any change, or any buy-in from the government or any other officials, you have to show the data that there's actually a problem. I think this is some of the issue that we have where you just say, oh, in my experience, this is the case. So like, okay, that's your experience, but does that really represent the whole? And that's why I like doing, qualitative and quantitative research so you can demonstrate like this is an issue, this is a problem. Everybody has experiences, but you have to really quantify these things if you want people to pour in money and resources to address the problem.
Thank you. Another thought, I was looking at what you presented for Black women in the US and Black women in the UK. And I'm like, oh, these things are just because I had a question of, what's the difference? But I don't really see it. And then the other thing is you would think because the perception is, people in the UK have more access to healthcare, right?
Yeah.
And that's always kind of presented as, well, this is why we have disparities because of lack of access. Could you kind of speak to the benefits and shortcomings of the healthcare system there, and I guess and the overall impacts on the Black women population?
Yeah, absolutely. I think that moving to the UK was, and seeing the data was huge because I was like, what? We have the same issue with socialized medicine. So it's not just access, right? It's the quality of care when you get it, And so here they're really good if you have an emergency, you get hurt and you go to the ER, you're in, your bill is zero, right? You want to get an eye check, you get out of there, you get 2 pairs of glasses, no issues, you're done. But the preventative things, right? So all the screenings you have, they do not, they are not so great with that. For example, you can't get cancer screening until you're over 50. 50 is really late, right? When you talk about Black women and breast cancer, in their 30s and 40s, like, 50 is really late. So that's one of the massive issues. Also, here there are long wait times sometimes when you're trying to get certain procedures done. And again, like I said, when it comes to emergency things, they're on it, right? You're hurt, easy.
Yeah.
But the preventative things are the issue. That's the major gap. And when I say they have access to care, it's still different. There's still massive difference between one side of town to another. So I live in Edinburgh, and within the city where you live, there's like a 5-year difference in life expectancy. It was like in the same city. Oh, really? What's happening here? Right. So we moved from one in the city to another, and it was very clear. So when you want to make a doctor's appointment, you have to get up and call at 8 o'clock, and you're calling over and over. You're getting the busy signal. You got to keep calling until you get through, and then they'll say, "Okay, yeah, you can get an appointment at this time." But you're called. By that time, you've been on the phone calling back and forth for like 45 minutes. No exaggeration. Okay, but on the other side of town, you can call whatever time, and it's like, oh yeah, sure, we could get you in tomorrow morning at this time or later today. It's very different. Yes, they'll get you in, but think about if you know that you need to go to the doctor and you have an issue, you need to set aside an hour at least to be calling, right? So
Yeah.
you really think about it before you decide, do I really need to go to the doctor? Is this something that really needs to happen, right? And in the US, the conversation is around, wow, well, it cost me $35 as a copay to go to the doctor. Maybe it's not that serious, right? So when you say access to care, yes, it's there, but it's also a difference in like, how you access that care, and the quality you might get. As you can see with some of the women that were interviewed, they talk about their pain not being taken seriously or just being dismissed. Yeah. So, and that happens on both sides.
Yeah. And going back to those quotes, and you kind of pointed out like the internalized racism where it's kind of like, well, it's okay, how can we help break through that? I've seen that more frequently, I would say, in the region that I'm currently living in, just the acceptance that it's okay. This is just the way they treat me.
Uh-huh.
Um,
I think that we have to learn the power of our voice, honestly,
mhm,
and not sit and accept the mistreatment. Right? It's not okay that they don't treat you the same way or the same, same urgency as they treat their white counterparts. And I think that the more that we accept it, the more they're going to do it. And they're like, oh well, we don't have to change anything. They don't care. Same thing when it comes to time for to get the potholes fixed in our communities. Like we accept that, okay, this road, whatever, Franklin Street is going to be tore up. We're not going to do anything. We're not going to call because they're not going to do anything, and they accept it, right? When you go on the
mhm,
other side of town, right, other side of town, they're calling immediately. There are graffiti on the wall. They come clean up. All of that is immediate. We have to learn to stop accepting mediocrity from the people that's supposed to be serving us. And
mhm,
just demand more, and understanding that it's okay to demand more. I think sometimes we just accept it because we don't want to be a pain. We don't want to be the one to cause the problem. Like, no, you're paying your taxes. You're paying the person that's supposed to be giving you service. It is not okay to be mistreated.
mhm. Well, I have one more question for you. And you talked about this throughout the presentation about just the chronic stress.
Mm-hmm.
And just thinking over just the last couple of weeks, the tragic events that unfolded, Buffalo specifically against the Black community, and how we have to live with this and then show up at home, show up at work,
Mm-hmm.
um, what is the mental health care like in the UK system? And what do you, yeah, I just want to hear a little bit more. Is
Mm-hmm.
it better than here? Is it what's your perception?
Um, well, I think that it's easier to get access. I mean, COVID has done a lot to backlog some of the like appointments and things. But
Mm-hmm.
again, if they're in distress, they're on it. It is definitely easier to get access to mental health. And I will say, even the institutions here gave people days off of work, Black people, days off of work after George Floyd was killed violently on camera. They gave them time
Wow.
off work. I was like, well, that's progressive, right? So it is, mental health is definitely something that's taken seriously here. I think the
Mm-hmm.
US could do better. The US could definitely
Yeah.
do better. I think that um, far too long, people have ignored the impact that these type of things have on our mental health. And it's one of those, oh, we accept that these things happen and move on, and that's kind of what it is. And I think
Mm-hmm.
that it's going to be important to just demand more and understand that it's okay. Like, you have sick days, take those sick
Mm-hmm.
days, right? A lot of times we are hesitant to take our sick days because, oh, they're gonna think
Mm-hmm.
we're lazy. Like, we work, is John Henry is one of those things where you're just working yourself to death, to prove that you belong in certain spaces. That's something that Black women have a huge issue with as well. Um, Working yourself to a point of exhaustion just to say you belong in that space. Like, no, they hired you, you belong in that space. This you know these terrible events have happened targeting our communities, and we need to deal with that, right?
Mm-hmm. Yep.
Mhm.
Totally agree. Are there any resources, any books, articles that you want to leave with our audience, or recommend that our audience check out?
Oh wow. um I really like it's called Medical Bondage by Deborah Cooper Owens, and it's an amazing book to talk about the history of gynecology in the US. And I
Mm-hmm.
use that book with my classes when I used to teach in the US. Another book is by Syke Forson Williams, called Building Houses Out of Chicken Legs. It's about Black women,
Mm.
power, and food. Um yeah, it's both of those books are huge, and there's another one called Raising the Race, and I thought that was really good, by Richie Barnes. I think yeah, her last name is Barnes. Raising the Race is about Black women and raising their families, and it was like Black women that chose to be stay-at-home moms and what it
Mm-hmm.
meant to be in that space, because people don't see us as stay-at-home moms,
Yeah.
right? And so they would be out with their kids and people assume they're the nannies. but she talks about that, right? And like some of these were professional women that were doctors and decided to walk away from their practices because they wanted to spend more time with their family, right? And I think that family is center to all of the work that we do. As you see, one of my areas is also Black family studies. So yeah, those are kind of 3 texts that I really enjoy reading. Yeah. So, and of
Thank
course,
you.
my husband book, if you want to talk about Black men, The Man Not is this corner right here. Yeah. The Man Not is about Black
The
male
Man Not.
vulnerability. Black male vulnerability. Yeah.
Well, thank you for sharing those. Any last comments you want to leave with the audience?
No, thank you for inviting me today. It's been a great conversation. I think that there's a lot of work to be done when we talk about Black women's health. I think that, again, we need to be okay with taking moments to take care of ourselves and understand that making yourself a priority is not selfish, right? And you will serve your community and your families better if you take care of yourself.
Excellent. Well, again, thank you so much for joining us. It's been a pleasure. We would like to have you back at some point in the future. This conversation was awesome. Not enough time to unpack everything in here, but enough to get us started and to really start thinking about these issues and ways that we can work to address them. So, Dr. Curry, thank you so much for being here. We really appreciate it.
All right. Thank you very much.
All right. And to our audience, we will hop on Clubhouse in a little bit. So please join us there. And we will see you soon. Take care.
I am the Liberation Movement.
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 I am the Liberation Movement. My name is Dr. Sidney Freeman Jr., and I am the Executive Director and founder of the Liberation Movement, which is a 501c3 organization that works with those who are liberated and seek to be liberated psychologically, socially, and spiritually through educational initiatives. To continue to provide the high-quality programming such as Saturday Soul, we need your support. Your consistent monthly investment in the movement will allow us to continue to expand on the excellent work that is already started, such as decolonizing the Black mind curriculum that is already in development. So your gifts of any size via Cash App, Venmo, or PayPal would be a blessing to the advancement of this ministry. Thank you in advance for supporting and joining the Liberation Movement.
Please remember to join Sydney, me, and our special guest today on Clubhouse at 2 p.m. Eastern Standard Time so we can dive deeper into today's topic. See you soon.